All right. Good afternoon. Thank you for staying to the very end of the second annual Maryland State of Reform. We are so pleased that you are still here. And hopefully, how's the day going for you? Good day? Well, we couldn't end the day without hearing from our very esteemed Secretary of Maryland Department of Health, Dr. Laura Herrera Scott. She and I had a joke about this a little earlier. She previously was the Executive Vice President for Summit Health, for Population Health at Summit Health, where she was responsible for executing on Summit Health's value-based care strategy. Before this, she had several leadership positions for AMPA, for the Maryland Department of Health and Mental Hygiene, as well as the United States Veterans Health Administration, where she worked on things such as population health, payment reform, delivery system transformation to improve health status and outcomes in underserved communities. Dr. Herrera received her doctorate in medicine from the State University of New York Science Center in Brooklyn, New York, and she received her master's degree here in Maryland in public health for the Johns Hopkins Bloomberg School at the Johns Hopkins Bloomberg School of Public Health. So, without further ado, because I know you all stayed just for her, let's give her a warm hand, Dr. Laura Herrera Scott.
Good afternoon. Really bright light, so sorry if I can't see some of you. She actually said either one of her kids or her dad would call during one of the sessions. So yeah, there you go. So one, thank you for having me, and two, thank you for staying around. I know I'm between you and wherever else you need to go this afternoon. And also, for some of you who I have not seen in a long time, it's great to see you all. And for those of you who I have seen recently, thank you so much for the very warm welcome that I've gotten in this role. As Robin already said, I'm Laura Herrera Scott. That's what we were joking about, how to really pronounce my name. And I'm excited to be here as the Secretary of Health. I want to thank you, Robin, HMA, for this amazing conference. And thank you for hosting such an important event around key health issues that are facing Maryland today. Over the course of the day, you've actually heard from many of the key stakeholders and leaders across Maryland's healthcare system, but you've also heard from several leaders in the Maryland Department of Health. So I think you've gotten a little flavor of some of the initiatives that the team is working on, as well as heard their passion and dedication to the work that lies ahead of us. So this afternoon, I wanted to take a few minutes to talk about some of my observations during the 5 short months that I've been here in my role, and some of the key health issues that I think are facing Maryland, and the opportunities we all have together to address these key challenges to create a healthier Maryland. You all have heard Governor Moore and Lieutenant Governor Miller talk about their priorities and their commitment to leave no Marylander behind. And the administration certainly envisions a state that builds systems that allows everyone to access health care to live their fullest potential. Strong public health and healthcare delivery systems that lower costs while increasing equity, quality, improving health outcomes are crucial to achieving this goal. But achieving this vision will require all of us to be working together. And in 2023, as we came out of COVID pandemic, I am clear-eyed about the significant challenges that face the Department of Health and our healthcare landscape. So first among these challenges, and there are several, but I'm only going to list a few, are certainly improving our delivery system in behavioral health. The American Psychiatric Association put out a very provocative paper, I think in October and November of last year, that talked about the history of inpatient behavioral health therapy to where we are today. And basically it pointed out how we've cut beds over the last 40 years. And the idea behind cutting those beds is that we would build those services in the community. The problem is we didn't build those services in the community, and what we did build is not adequate to meet the needs of all the people that need those services today. So we have a woefully underprepared system to address the needs of our community. In addition, if I think about the work we do on the physical health side, it's a continuum of care. You have primary and secondary prevention, primary behavioral health care, urgent care, emergent care, post-acute care, end-of-life care. Behavioral health is a little more confusing over where you access care, and it's not laid out as a continuum of care the way we have it on the physical health side. And we need a behavioral health system that works as a continuum of care, that includes prevention, culturally competent crisis services, addresses ongoing mental health needs and substance use needs, and supports individuals who are re-entering their communities. Moreover, we need to set our sights upstream to prevent and address trauma. We know ACEs, which is a 10-question screening tool. If you score 4 or more on that tool, your risk for having anxiety and depression as an adult is significant. So what can we do in elementary school and middle school and even high school when we use those tools in our school to start providing services locally to improve health outcomes for those as adults? We envision a state where all Marylanders have real-time access to high-quality and equitable behavioral health care. This fiscal year, the budget that passed by the General Assembly included an additional $107 million plus investment in behavioral health. So this was over and above what was already being funded for behavioral health. And we look at it as a down payment on improving the behavioral health continuum of care, but this is just the beginning of ongoing process. The past session, the General Assembly also passed House Bill 1148, a comprehensive behavioral health piece of legislation that creates a commission to examine behavioral health resources in the state and make recommendations for improvement. The commission will inform the work done by the department and the Behavioral Health Administration to assure a world-class behavioral health system in Maryland and in the future. And because I'm looking straight ahead, I see Delegate Bonnie Cullison, and who was certainly a champion of the bill, so we thank you for your work on this bill. There might be others, but I can't see with the light. But certainly an important piece of legislation as we advance behavioral health as a priority. Access to care and the cost of health care impacts families and continues to be a challenge for too many Marylanders. We know that too often bankruptcies are tied to medical issues, either because of high costs for care or time out of work. We have high deductible health plans, we have high copays, we have families that have been dealing with the inflation that now unfortunately have to make decisions between paying their rent, their food, or their health care. Families have really hard decisions to make, and sometimes the health care choices are the last on the list. Maryland and the nation are undergoing a significant effort with Medicaid renewals required under federal law, and we are grateful to our managed care organization partners for their commitment to helping ensure that eligible Marylanders remain in coverage. Just last month, or maybe 5 weeks ago, we heard from the Latina Alliance that we were not doing a good job communicating to our monolingual Spanish community. We reached out to our MCO partners and said, will you do a press conference with us in Spanish and English, which my understanding, it was the first done in many years, if ever. And our managed care organization partners quickly stepped up to help message that it was time to renew for benefits, and we did it in Spanish and English. So we thank our MCO partners to helping get the message out. Ryan, I know, was here earlier. I'm not, oh, there he is. And I'm sure he went over this, but want to say it again. Our first month of data, the good news is that over 76,000 Marylanders renewed and were able to keep their coverage. Of this number, approximately 5,500 Marylanders had not provided updated information, but because of new authorities that have been provided by CMS, we were able to use some innovation in the data we have around supplemental nutrition assistance program to keep those people covered. Approximately 10,000 Medicaid recipients were determined to not be eligible based on information provided and were disenrolled. And we're actively working to see, were they qualified for other plans in the exchange? Did they have employer-sponsored health plan? But we will be reporting this data publicly as we learn more as the months evolve. Of particular focus for us is the approximately 24,600 participants who did not renew their Medicaid coverage for a procedural reason, such as not providing updated eligibility information. And I'm sure, as Ryan said earlier, and maybe I'm hoping you said this, we are absolutely committed to looking more deeply into the data behind these participants and how trends and our trends over the next few months. And as I mentioned, in addition to the SNAP waiver authority, we are looking and have requested several other authorities to keep denials for procedural reasons to a minimum. Compared to other states, we've done a really good job. The data was limited to only 6 states so far, and of those states that had compressed timelines, so we'll see how the state of Maryland compares over time. But we are actively working to keep as many people enrolled in Medicaid as we can, and we certainly need your help in this effort. We ask all healthcare stakeholders in Maryland to encourage Medicaid participants to check in and ensure their information is up to date. Our entire delivery system is better off when all Marylanders who are eligible for coverage are enrolled in and keep their coverage. And healthcare coverage is key to better health, but we also know that having health coverage doesn't always secure a visit with a provider or accessing needed health care. Our healthcare system can be difficult to individuals to navigate. I consider myself a pretty sophisticated healthcare user, and I've at times struggled with not only the explanation of benefits I receive, but navigating the system for my family. And as you all well know, I would be remiss if I didn't talk about our healthcare workforce and the tremendous challenges as we emerge from COVID. Every morning when I come in, I look at all my different RSS feeds from the different news sources that I read, and one that I was reading on Monday talked about a survey from McKinsey that surveyed a subset of the 2 million inpatient nurses that currently work in our facilities today. And by their survey results, the expectation is that up to 42% of that nursing workforce is going to retire in the next few years. And so how do we start thinking about not only the impact the pandemic had on that workforce, but how do we start planning not only immediately, but then longer term? Again, the workforce has had significant challenges, and we've certainly added to that with some of our operational difficulties at the Board of Nursing, and that's one of the areas where we are actively focusing on due to some recent legislation that moved the Board of Nursing under the Maryland Department of Health. We are getting them back online. We are actively working on an RFP to get a online licensing system and have made several other changes in the short term to improve at least the nurses that want to work in our state to ensure they are able to get their license to work. And our primary care workforce is under strain. We need to think creatively about a development plan for that workforce. As I mentioned, we are working to improve operations and processes at the boards. We are examining ways in which we can better leverage the use of non-clinical supports, such as peer support specialists, community health workers, and doulas, to bolster our healthcare delivery system and advance health. We are identifying ways to promote opportunities for loan repayment, especially in healthcare professional shortage areas, to attract professionals, not only in underserved areas in rural Maryland, but even in certain neighborhoods in Baltimore. And we also need to continue to invest in primary care. We are asking primary care providers to do more than we have ever asked them to do before. I am a recovering primary care provider who worked with 15-minute RVUs, and I can tell you that was never enough time to see patients. And not only was it not enough time to see patients, but if you had asked me to close gaps in care, to make sure they left happy, to make sure I did a PHQ-2 as a screening tool, I think I would have run even later than I normally did. But we know that if people have a connection with their primary care, they have better health outcomes, have more appropriate health care utilization, and overall do better. So it's a problem we need to solve for. And how do we make primary care a profession that people want to answer, want to do, and how do we compensate them appropriately? Right now, we are working closely with CMMI to develop a proposal for a Medicaid-aligned version of the Maryland Primary Care Program to further investments in quality in the key service and profession for Marylanders. And we can't do that with primary care at the table. And that includes pediatricians. I believe we can make progress on many of these key issues, though policy and partnership with stakeholders represented in this room, as well as the community statewide, are incredibly important. We have the tools and assets in Maryland to address these issues. We need to work together on the strategy and prioritization. We also need to make sure we have the right incentives in place to ensure Marylanders have access to right care at the right time. This leads me to another key challenge facing our state. Though we live in a state with incredible wealth and resources, I think we're actually #1 or #2 in the country, we have shocking disparities in health outcomes. For example, Baltimore City and counties in Western Maryland and the Eastern Shore fare far worse than the national average on measures of access to needed services and health outcomes. And even though Maryland's overall average is better than the nation, we have communities that are suffering. Years ago, when I worked at the Baltimore City Health Department, we actually did map this out geographically, and between 2 zip codes in the city that were only about 5 or 6 miles apart, there was a 20-year life expectancy. And when we map that out across the state, we still have communities in the state where life expectancy is significantly lower than the rest of the state. So we have much work to do. Advancing equity and health outcomes throughout the state is a key focus through the department and the administration. Legislation in 2021 created the Maryland Commission on Health Equity, and the department is committing to reinvigorating and supporting the work of the commission to improve availability of data on key disparities and recommend policies to improve health outcomes for everyone in our state. Most recently, I had the fortune of visiting our wonderful partner, Hilltop, and I see Cynthia in front of me, and we learned that we can now provide race and ethnicity data on over 95% of our population. So we will be looking at that data broken out by quality measures where we can to start assessing how we are doing as a state. And I've certainly asked our hospital partners what they can share related to race and ethnicity so we can start shining the light on disparities in healthcare, both based on demographic information, but geography as well. Finally, we have a significant opportunity to improve health in Maryland through the evolution of our total cost of care waiver. What started as a hospital-focused effort has continued to expand outside the walls of the hospital for the past 10 years to further community and population health. The Moore-Miller administration is committed to advancing Maryland's unique total cost of care model. We are committed to working with stakeholders to advance the model and have identified the following areas for further development. Further advancing health equity throughout the model is a key priority, and it's a priority across the administration and everything we are going to be doing. Aligning Medicaid and private payers with payment models such as Maryland Primary Care Program and Episode Care Improvement Program. Pursuing value-based arrangements and improving coordination in the post-acute care setting. And ensuring that the model allows Marylanders to access the services they need when they need them without undue delay. I also recognize that community health doesn't and should not fall solely on the hospitals. We have incredible resources in our local health departments, community providers, community-based organizations, and others who are providing key services to Marylanders. Faith-based organizations served an incredible role and were incredible partners during COVID-19 in building the trust in our communities to get them vaccinated for COVID-19. We want to continue that partnership with them as well. We need to ensure that key stakeholders are at the table for the next iteration of the model to advise on its development and implementation and are incentivized and empowered to address key population health goals. In closing, I'd like to thank you all for your work improving the health of Marylanders and your partnership to date. I've highlighted a few priorities of the department, but there are certainly way more, and happy to answer any questions about the other ones. But I look forward to the partnership going forward. We have an extraordinary amount of work to do, but working together, I know we will be successful. Thank you. Thank you for the warm welcome, and I look forward to working with all of you.
All right. This is the part of the show where you get to ask Laura some questions. I'm not going to flip the script on you and have her ask you questions, but if you don't raise your hand soon, she's going to start asking you questions. Oh, over here.
Oh, there we go. Thank you. Thank you so much. Thank you, Secretary Dr. Herrera. My name is Delegate Robin Lewis. I represent the 46th District, and I'd like to welcome you to my district. It's an honor to have you here, and it's such a thrill to have you as our Secretary of Health, so thank you for all you do. I'm curious, when you refer to the importance of racial and ethnic data on measuring and monitoring health outcomes, I wonder if you could talk a little bit about what we know and what we're doing to tackle maternal mortality in Maryland, particularly with regard to race and ethnic disparities in that health outcome. Thank you.
So we know Black moms across the country have worse outcomes across the board, and not only are we looking to maternal mortality and maternal morbidity, but certainly babies of color as well. And so the department, we are working on a women's health strategy right now. We are working, we certainly have implemented doulas for moms who will accept working and partnering with a doula. But we have a lot more work that we need to be doing in this space, not only in preconception care, and since we know more moms are entering birth or pregnancy with chronic conditions, and so making sure their chronic conditions are optimized prior to becoming pregnant, making sure they engage with prenatal care earlier than they sometimes do. But we have a lot of work to do. And certainly we will be doing that in partnership with our managed care organizations, with our private payers, and with our hospitals to do that. March of Dimes gives us a D+ on premature deliveries and infant mortality. So we really have a lot of work to do. And we really, in certain counties more than others, so we want to be intentional with our efforts to focus on the areas where we want to start with that work.
Good afternoon, Secretary. Thank you so much for just coming to see us today, right? I wanted to ask you, so my name is Jean Drummond with Healthcare Dynamics International. We've done a lot of work with the state, and particularly as you're talking about the workforce, thank you for what you're doing with for the nurses, but for the community health workers, and I also appreciate the doulas, the promotores. How do you see, talk to us a little bit about the future. I mean, when we're thinking about a workforce retiring, community health workers are so vital, you know, to community-based physicians in so many ways as we're trying to go value-based care, we're trying to get more, trying to address social determinants. And I just really think that that group could be really expanded. So talk to us a little bit about your thoughts in terms of the future of promotores and community health workers and their integration you know, into the broader healthcare system long-term as we try to, you know, ensure financing. Especially with the Maryland Medicaid, with the CMS waiver that you're working on as well. I'm sorry, I wanted to put that in.
So I totally agree on community health workers. In my prior life, I was here as the Deputy Secretary of Public Health, and in that role is when we started the community health worker role, and we actually looked at several states and looked at their education and training to move the community health workers that we had to some standards so we could move them to certification and ultimately reimbursement. So incredibly important partners. I don't know where we are in the landscape right now to comment one way or the other about what we're doing and where we're doing it, but totally agree that they are vital to providing services in the community. We know that they are a trusted partner, sometimes more than their primary care provider or the delivery system, and they know the community and what their community needs. So we have to figure out, one, who's doing what where, who's doing it well, and then how do we learn from who's doing it well to expand that work. So I have a lot of learning to do in that space. It's been too long for me to comment on what we have today, but totally agree, they are important partners. I would be remiss if I didn't also mention peer support specialists and other paraprofessionals that are really, really helping our patients engage in the delivery system and then be successful in the delivery system. Any other questions? Oh.
Thank you. Thank you so much for being here today. Boris Lushniak, I'm the Dean of the School of Public Health, University of Maryland in College Park. As you take on this leadership role, and I congratulate you both on your career up to date, as well as the challenges ahead, what do you perceive are the roles of academic centers? You have a university school of public health we're a state supported university, a school of public health. You have Johns Hopkins here, obviously your alma mater. You have programs of public health throughout the state. What's the interplay between you now in this leadership position and the academic side of the house? What can we do for you?
Lots of things.
Yeah.
Lots of things. So workforce, one. So how do we, with the people that attend the schools, work out arrangements where maybe they can come spend a month or two as an elective learning about real delivery of public health so they can take what they're learning in class and translate it into the real world and hopefully create a pipeline for the state of Maryland, our public health system at the state level and at the local level to want to engage and take that on as a career. Evaluations of some of the things that we're doing. So how can we partner with you and the other public health schools as we develop new programs to help us decide, are these programs working or are they not working? And if we want to take them to scale, do we have the right information to do that? And then lastly, you're doing your own research. Some of it is applicable, or much of it that's applicable to us. How do we start translating that research into practice and take things to scale that could have meaningful impact to the communities that we have? Not to mention informing policy. So what are the lessons learned that you're doing on the academic side that would help us inform policies? And you can pick your area: environmental health, tobacco, maternal child health, and impact on Black moms. But whatever those things are that you're currently looking at today, I'm sure there's a niche for us at the department to partner, learn from each other, and then share that knowledge or use it to develop new programming for the state.
Great.
I think
Sorry.
there was one more question.
One more. All right, last question.
Hi, Luke Carlson with MedStar Health. One of the groups that was hit hardest by the pandemic were the skilled nursing facilities. And upstream of this led to prolonged hospital length of stay, ED boarding, and even further prolonged ED length of stay, or ED wait times. What opportunities do you think we have to support the skilled nursing facilities from a policy side? And what role do you think that advanced home care services would have in that to act as kind of a pressure valve to release for skilled nursing facilities?
So we have a lot of work to do on the skilled nursing facilities, and I've been meeting certainly with their coalition groups to understand where we are with skilled nursing. I know at least for the paraprofessional, the CNAs and the GNAs. There's some policy work that we need to be doing there just to level the playing field and access to that professional in the nursing home. They're having their own nursing shortages and the ability to staff beds. And the problem is because there's statewide nursing issues, people are going to the highest bidder. And so working with them on their staffing needs and how do they bring more beds online so we can create the capacity in the hospital for discharges. So there's a lot of work that needs to be done there. I will also say we're thinking about them, as I mentioned in the waiver, and we didn't spend a lot of time doing it, but we did a very brief literature review, and there's actually not much on value-based payments with skilled nursing facilities, and so trying to think about, well, what that looks like in the next iteration of the waiver, because they are such important partners. As far as home-based services, I don't know, there's a lot of companies now that are getting into that space, and I think the evidence behind it is still questionable. It makes a lot of assumptions. One, that there's space in the home to set up home-based services, that there's a caretaker, which then becomes the de facto provider of care outside of the short time that a nurse is there infusing or doing what they're doing, but is there infrastructure in the home to be able to provide those services? So I think we need to think about that and what the impact is to families if we were to move to home-based care in lieu of a skilled nursing facilities. I think for the families that could do it, they really, really like it, but they tend to be the families that know how to navigate the delivery system more than the families who don't. So will we create some disparities in that just based on access to those services and the wraparound services that those families can provide? So we have a lot of learning to do in that space, but skilled nursing facilities are something that we're looking at for sure as we think about the next version of the waiver.
All right, thank you for those great questions. Let's give Laura, Dr. Scott, another round of applause. Thank you so much for gracing us with your presence this afternoon.